Morning. Thanks, Chairman. So, isolation and identification of common and uncommon bugs. So, basically, the talk is how to increase your yield of growing these bugs. So, this isolation and identification, so far, maybe even about 5 years ago, was all mumbo jumbo. The knowledge and practice in this field was very primitive and very unorganized. Now, the two people have changed the scenario. One is Jay Parvezi, who's to talk later. Is Jay here? You can't talk on this topic without mentioning Dr. Parvezi and Thurston Gurke from Endoclinic. They have really revolutionized this subsect of this specialty, and now we are able to culture more bugs, and we know what to do these days. So over the last 5 years, the practice in our hospital in this field has changed dramatically. So just like any other specialization that you have in orthopedics, bone and joint infection like tumor is a subspecialty, and we must recognize that. So we have a consultant who does only this work. He doesn't do anything else. So he's a full-time bone and joint infection consultant in orthopedics. Yeah. The first thing that you got to do in a hospital is have a periprosthetic joint infection team. So in our hospital, we have the orthopedic surgeon who got a special interest. We have the ID specialist. Dr. Ram Subramaniam gave an excellent talk, and I'm sure they have that in Apollo as well. And we have a microbiologist with a special interest in musculoskeletal infections. We have a radiologist with a special interest in musculoskeletal radiology, and we have a periprosthetic joint infection nurse. And they're all in this WhatsApp group, and every infection that comes to the hospital, we get a lot of referrals as well. This group is on the ball. It's very important that you take special interest to increase your success rate. The enemy here that we are fighting, jointly fighting, is culture negative infections. So 5 years ago, our culture negative infections was over 50%. I'm sure you'd all agree. In your own hospitals, it's very high, but currently it's less than 20%. So my talk will take you through the various steps that we did, that we brought the 50% rate down to less than 20%. The first thing is, if you ask any lab, the most frequent specimen that they receive is chronic wound discharge, either from a sinus or a chronic discharging wound. This is a complete waste of time. Not only is it a waste of time, it leads you to the climb the wrong tree, you give wrong antibiotics, completely contaminated specimens. So the acceptable specimens in orthopedics today are aspirate tissue samples. Remember, bone is a good specimen. Not many may be aware of that. To send to the lab for your microbiological cultures, you have synovial fluid, you have swab cultures, and of course implants themselves can be sent these days. So the dramatic thing that made a difference was we have an OPD puncture clinic. The traditional concept that we used to learn as postgraduate is that whenever we aspirate a joint, we got to do it in the OR. That's completely given up now. Because once you have to schedule a patient in the OR, a lot of logistics are involved. And you have to spare your time, etc. Not necessary. You must do this in the OPD. So, however important the patient must be off antibiotic, preferably for 2 weeks. Again, logistically not possible. So, we think 1 week is good enough. So, the knee we're able to aspirate without ultrasound. Shoulder we're able to aspirate. But the hip, ankle, and elbow, we need ultrasound guided. And any collection that you have in the musculoskeletal system, you need ultrasound. So you must have a radiologist who's good at this, and we're able to aspirate in the radiology department, and that's where all our aspirations are done. No more sending specimens of chronic discharging wound. That's a complete waste of time. So once you have a radiologist who's interested in this, things become very easy. It must be like sending for an X-ray. You mustn't think twice. You send them to the puncture clinic immediately. You don't think twice whether should I aspirate, should I not aspirate. It's just like getting an X-ray these days. Rarely, of course, we have to take the patient to the OR, especially for the hip, where we need a C-arm, we take them to the OR. Otherwise, we never take the patient to the OR for a puncture. And that has really dramatically changed our practice. The transportation, if I want to give you one message today, this would be it. So traditionally, we used to send specimens in sterile containers. That the yield is very poor, and you may get contaminants. So the thing to do today, in 2018, is to use a pediatric culture bottle. Why pediatric culture bottle? Because only 3 cc of fluid is enough. If you want to use an adult culture bottle, you got to give 2 bottles, you must have 5 ml. So aerobic and anaerobic, but in a pediatric, it will take care of aerobic and anaerobic and need 3 ml. It's rarely that we get 5 ml. So 3 ml would do, and this is really, really revolutionary practice. Yeah. So we send so we inoculate yourself. You must inoculate yourself. So as you draw the specimen, you must take a pediatric culture bottle and inoculate it yourself. And these are broths, and there's been a lot of evidence to show that will increase your yield dramatically. So if there's one point that I want to give you, and one point you want to change your practice tomorrow, this is what you should do. So if we use broth cultures, to increase the yield, and this paper shows the yield increase from 95% from 83%. So how many intraoperative specimens you want to send and from where? So general rule is that the more the specimens you send, the better would be the thing. But we can't send 100 specimens. So there has to be a balance there. Should these specimens be obtained before the initiation of antibiotics? That's the traditional teaching, but now it's not proven not to be true. The anesthetist can give the antibiotic and can still send specimens. That doesn't change anything at all, yeah. But you must use a separate instrument for each specimen that you are sending, and the container must be different for different specimens, yeah. The most important thing of all this, the transportation must be prompt to the laboratory. The commonest mistake is that you take the specimen, the nurse leaves in the corner of the OR, and then it goes after 24 hours to the lab. That's a complete waste of time again, yeah. So remember that a single positive sample is unlikely to be significant. So if only once of your specimens grew a bug, that is insignificant. Isolation of the same microorganism from 2 or independent specimens is highly predictive of infection. So one specimen is a waste of time. So now we think the magic number is 5, but minimum, if it's less than 3 specimens, it's again a waste of time when you're doing OR specimens, yeah. So what are the various things? The joint cavity, synovium, the implant interface, the femoral canal, acetabular floor, the fat pad, etc. can be sent for culture. Now, once we have infection, the nurse is running around for a sterile container, your assistant is doing something else. So we now have what is known as all in a box. So all that you want to send as a pack must be available in a single unit so that there's no confusion in the OR as to what you are sending as well as the labeling. Yeah. So this all in a box technique is very useful. So this is what we send usually. So the gram stain, Arabic, anaerobic, fungal, mycobacterium, the routine cultures. We have the automated cultures as well, the PCR for tuberculosis. Now histopathology can be useful in infection. We know it's very useful in TB. It can also be infection to say an yes or no. Just like you have your ALVAL scores, we now have infection scores, whether it is septic or aseptic. Can be useful in some situations. Yeah. If you can send the implant, some hospitals have sonication and vortexing, which are useful to identify, to separate the biofilm and culture that. So if you have this facility, it's very good. If you don't have it, nothing much is lost really. So what is the time taken to identify these pathogens? The gram stain and AFib stain is immediate. Aerobic 5 days, anaerobic 5 days. Fungal is, and mycobacterium takes 42 days. Now routinely we use this Malditoff in many labs, which is basically a spectrometry, and that is sort of parallel to your cultures, and that also can give you a good deal. So you always do both the Malditoff as well as a routine agar. That's what we do in our hospital. So here is 2 papers which say the time needed is more than 7 days. So if you give your antibiotic or you base your entire thing on your initial cultures, that it may not be true. So you got to wait. So how long you wait? So here is a graph showing you different organisms. You need to wait for different periods of time. So you can see that the acnes it takes up to 10 to 12 days. So now we believe that the golden period is 14 days. So you must wait for 14-day cultures before you decide on the final antibiotic therapy. So the 14 days we believe now is the magic period. In spite of all the newer trends, we think that the time-honored concept of a broad range bacteriological media still holds good in 2018. Now, as Dr. Rajasekhar was talking about, we are now moving into non-culture techniques for identification of bugs. So the important things that has now come into vogue are the synovial cell counts, biomarkers like alpha defensin, I'll talk about it, as well as leukocyte esterase, and the buzzword today is next generation sequencing, or NGS. So synovial fluid now plays a very important role in the diagnosis of joint infections. So you must do your CRP. ESR may be not very effective. Your CRP and cell count, white cell count of your synovial fluid is so critical these days in the diagnosis of infection. And you use your biomarkers. The 2 common ones used are leukocyte esterase and alpha defensin, which just come into India, and we do use it. So leukocyte esterase is a biomarker for the synovial fluid. It is secreted by the enzyme, secreted by the neutrophils secreted close to the infection. Yeah. So initially it was like a pregnancy test, whether it's infected or not. It's a dipstick test, but now we believe that the sensitivity isn't that great. It's fallen down to about 80%. The other biomarkers are alpha defensin. I'll talk a bit about that. Procalcitonin, interleukin 6. We have CD14 and CD10 as well. The alpha defensin is an interesting test. Initially we thought again it was 100% specific. Now again the recent paper shows only about 80%. Again a biomarker if you have a fluid, and the alpha defensin test can be very useful in the whole scheme of things. PCR, of course, useful. We use it for TB, of course, our gene expert test now. But the problem with the PCR is you must know what organism you're looking for. Otherwise, PCR is no value. So the real revolution today is NGS, as Dr. Rajasekhar was saying. The human genome was sequenced over a couple of decades ago. But now the same work done over 2 decades can be done on a single day using NGS. So that's really revolutionized. So this is a paper by J. Parvasi again, shows how in their series, culture negative infections, which are 17 out of 28, so they were able to culture 11 more cases. So almost a 100% yield rate when you start using NGS. So this is truly the revolution today is NGS. Another paper by J. Parvasi, which says this patient of his had this infection negative in all cultures, but NGS grew a very strange bug, Streptococcus canis, which I believe grows in the buccal cavity of dogs. And this gentleman had a wound, and he had a dog, and that's how he got his infection. So in conclusion, I would say that today in India, in all your hospitals, using all these techniques, your culture negative PGI must be only 15 to 20%. If it's more, you're doing something wrong. So with all the current principles and guidelines combined with the modern non-culture techniques, culture negative orthopedic infection may be a thing of the past. Thank you for your attention.
Please join us here, Vijay. This forum is open for questions to take discussion. All the speakers are on the dais. Anybody who has a question, please walk up to the mic, identify yourself. Yes, Amulya. Question 2.
Good morning, sir. This is Dr. Amulya from Patna to Professor Raj Shekharan, sir. Sir, what you told about this disc infection, there's going to be an evolution and we are going towards a different scenario as such. What do you feel like in the coming days, pre-operative antibiotics will help us or some other changes has to be there?
Thank you for the question. Actually, this is the raging controversy in spine surgery. And 4 years before, the torpedo was a paper in Lancet, where Albert et al. Had treated people with severe back pain with augmentin. And they reported a significant difference in the outcome. And they told that all back pain, or at least back pains with type 1 modic change or infection, and they should be treated by antibiotics and not surgery. There's a big controversy. I mean, I can talk to you about it for hours. We are also involved in a big research in this, but I think there is a lot of sense in thinking that many of the disc inflammations with modic change giving rise to back pain is due to infection.
Dr. Devinder at mic 1. Question 2.
I think in the India we are more trauma surgeon. We are doing more of trauma surgery than arthroplasty surgery. And focused to that, I have a question that often we receive as an orthopedic surgeon, patient with multi-trauma. Patient is having chest injury, patient is having head injury, and GCS is low. My question to Dr. Subramaniam, how to plan antibiotic prophylactic protocol in this kind of patient? Does they need an antibiotic for catheter? Does they need antibiotic to prevent the chest infection?
No, I wouldn't suggest antibiotics for catheter or lines which are being done electively in the hospital. What we probably need to give is they may require antibiotic prophylaxis if they have complicated fractures, if they have contamination of their injuries or deeper injuries, penetrative injuries with a skin break. Which situation, a simpler antibiotic, usually I would suggest a second generation cephalosporin or a coamoxiclav or a clindamycin as possible agents you have used. Because it is inevitable if infection is going to happen, it is going to be selected out by the antibiotic and what you're going to get subsequently will be resistant. So going for simpler antibiotics as prophylaxis is much better than going for bigger guns before.
Okay, what about the chest? Like if a patient is having a low GCS, the Glasgow Coma score, and patient is dumped into the orthopedic ward. What about the chest infection? How to deal with that? Is there any prophylactic protocol to be followed? Because orthopedic surgeon is the one group of surgeon I think blame most that you are the most inadvertently using the antibiotic.
That's true because we tend to rely on antibiotics for a lot of things. I think getting the patient better and mobilizing sooner is what we need to look at. Antibiotics are only a stopgap and it should be used as limited as possible.
Okay.
Yeah.
And
Mike,
I have one
Devinder,
more,
wait.
question, sir. Just one more question.
You have to give others a chance. We'll get you to Vijay after this. Mic 2.
Sir, my question to Dr. Raj Shekharan, sir. Sir, your deliberation has risen a lot of questions, but one question I'd like to ask. Sir, you have mentioned in your deliberation that a lot of pathogen association with different kinds of orthopedic illnesses, as for example, the adhesive capsulitis. Yeah, exactly. And here organism we have noted the Propionibacterium. Now, sir, we are coming in a stage that for those diseases we are treating conservatively or by some analgesics, should we start antibiotic for this? Is your message or something else, sir?
Yeah, we have not come up to the stage
Right,
where
sir.
we can conclusively say start antibiotics. But we are getting closer to the stage where we are understanding that many of the diseases which we thought as idiopathic
Yes, sir.
are now actually due to low-grade infection. This is a boiling pot.
Yes, sir.
I mean, so many thought process, so many new findings, so many new ideas are coming just almost every day in major journals. I think the next 5 years will actually define what exactly we should do.
Thank you, sir. And I would like to thank Dr.
One
Ganesh.
question per, please.
No question,
Next.
it is thanks, sir. I have a
Send him
thank-
an email. Next, please.
Okay, sir.
My question is to
Sir, I'm Dr. Chavan Raikrishna,
Yes.
Professor of Orthopaedics, SVS Medical College, Babanagar, Telangana State. Sir, in culture negative specimens, what is the role of rifamycin?
Rifampicin is a very useful adjuvant when you are treating where there is a foreign body in place, you cannot remove it, and there is a strong possibility of a biofilm being present. So rifampicin is given as an adjuvant to the usual antibiotic agent, mainly for gram-positive infections. Role for rifampicin alone, no, there is nothing, and role for rifampicin in the absence of a foreign body also, I feel, is very limited.
Mic 4, please. Just one. Mic 4.
sir, my
I am Dr.
question is
Atul from Ayodhya. My question is to all of you that considering the poor hygiene of our most of the people who are coming from periphery, from rural areas, do you suggest that the protocol of peri-operative period of 1 day is sufficient or it should be more than that?
Simple yes or no answer.
Absolutely sufficient, because what happens is only during that time. Continuing beyond that has no effect.
Yeah, one line answer.
sir, continuing
One line
to
answer is that also people with poor hygiene have also got very good immunity.
Okay, Dr. Pratyush.
My-
Mic 1.
I am Dr. Pratyush Chatterjee from Calcutta. My question is to Dr. Subramaniam.
Very popular.
You say you said you have set up a new protocol for the prophylaxis surgery. One antibiotic IV 1 hour before surgery, and one in the evening, probably. This scenario of the protocol of prophylaxis surgery is changing probably every year. Sometimes back we were told to use 3 antibiotics, one pre, one par, one post-operative. That's all. Now you are saying one hour before surgery. We were told that during the intubation period, the maximum bacteremia occurs, so that is the time, best time to give an antibiotic, IV antibiotic. Now you say 1 hour prior and 12 hours later. So,
No, I think what happens is the problem with infection happens when you incise and the bacteria there enter the bloodstream. So the antibiotic should reach a maximum level in your blood when this happens. So it should be given within 1 hour prior to insertion. It can be during induction, it can be half an hour before, but it should be around that time, perioperatively. If the surgery lasts longer than 3 to 4 hours and it is beyond the half-life of the antibiotic given, you need to give an intraoperative dose.
the anesthesiologists say that it is during intubation.
No, intubation does not cause bacteremia.
Yeah, okay, fine. Mic 2.
Dr. Mukhi from Bombay. I want to know from the whole faculty whether body exhaust system, does it work in joint replacements for prevention of infection?
No, it's not a matter of working. Is it better, than not
okay.
using it?
Yes.
What's the consensus of the faculty? Yes or
So,
no?
no, I think both laminar flow system and body exhaust system are now considered not
Overhyped.
absolutely required.
Absolutely required.
Not
No,
absolutely.
exactly.
Not-
There's
not-
more hype than reality.
Yeah, more hype than
So,
reality.
mic number
Not
4.
is NOT.
Mic 4.
Myself, Suman Sinha from Delhi, sir. My question to all panelists. See, recently in the Western literature, there is much hue and cry that Indian people are using so many antibiotics, all left and right. This misuse of antibiotic has raised to many notorious organisms. So, what is the advice from this forum? Couple of people are using the antibiotics very judicially, and rest of the country are using it very right and left way, even any Tom, Dick and Harry can use any antibiotic for any long time.
So 4 or 5 very simple take-home messages. One, limit your prophylaxis only for major surgeries involving foreign bodies, that to 1 dose before and maybe 1 more dose in the next 24 hours, not longer. 2, before starting empiric therapy, always send culture so that you will act better when the cultures are available. 3, delay starting broad spectrum antibacterial agents unless the person is in sepsis or septic shock. 4, after you get the culture report in 48 to 72 hours, reassess and de-escalate to a more narrow spectrum antibiotic. And 5, try to give as short a course of antibiotic as possible.
Okay, mic number 3. The other speakers, come here, we will answer your questions personally. Last question from mic 3. Mics 1 and 2, please join us here. Your questions will be answered.
Dr. Rathaswamy from Tanjavur. In peripheral hospital like Tanjavur, the culture report comes as negative for all the organisms, all the antibiotics except co-triamoxone and tetracycline. Whether it is of use or not used, I want to get help from Dr. Ramasubramanian.
I think we have to improve the standards of our microbiology lab rather than resort to using more and more high-end antibiotics. So if I ran a hospital or I was involved in major surgeries, the first thing I will do is invest in a good microbiology setup, sir.
Thank you so much. This ends the session.